Thank you for those of you who are joining on behalf of the University of California Center for Climate Health and Equity, the Eco Health Center, and the University of California Climate Change and Mental Health Council. We welcome you today. Our six-part webinar series on urban wildfires and protecting health and well-being is co-hosted by UCLA Center for Healthy Climate Solutions, the Fielding School of Public Health at UCLA, the Sustainable LA Grand Challenges, the UCSF Alumni Association, and the communications team, both at UCSF and the UC Office of the President. I want to reiterate our thanks to our incredible team of faculty and staff who have put this webinar together in a very short period of time, including my CCHE co-director, Sherry Weiser, Elissa Epel, who you'll hear from a lot today, and Jyothi Mishra, who run the UC Climate Change and Mental Health Council. David Eisenman, Mike Jarrett, Jennifer Shear, Claire Brindis, Tarek Ben-Marnia, Neetha Thakur, Robin Cooper, who you also hear from today, Philippe Golden, Sigal Maya, Anne-Marie Charlesworth, and Annie Rosenthal, as well as everybody at the UCSF and UC Office of the President who's helped us. The impact of the LA wildfires on livelihoods and health will be really continue to be felt, with over 57,000 acres burned and 16,000 plus structures destroyed. Many have lost lives and have been injured. For those who have lost their homes and continue to seek shelter and support, and for those returning to their homes and spaces, the health and mental health impacts are yet to be determined, and our hope is that this series will help us prepare California and the University of California communities to protect themselves. In today's session, we're going to hear from experts, to talk about the impacts of wildfires, especially as they're relevant to psychological first aid and communal support for acute stress. Immediately after climate disasters, it's critical to help people who are impacted get access to psychological first aid tips and community support. Our webinars are recorded. The links will be sent out after this to those who signed up, and we are working on translations in Spanish. You can find the resources on our website, and we're also going to include them in the Q&A for you to have access to. And our sessions will continue to follow the same format for the next weeks to come. I'm going to turn to our esteemed moderator, Dr. Elissa Epel, who will introduce our panels of speakers and also really moderate this session. Dr. Epel is professor and vice chair in the Department of Psychiatry at the University of California, San Francisco. She is the director of the Aging, Metabolism, and Emotions Center, associate director of the Center for Health and Community, member of the National Academy of Medicine, and past president of the Academy of Behavioral Medicine Research. She is leading the Mental Health Council in the center, which really focuses on climate distress activation and has been a real force behind this work. With that, I'm going to turn it over to Dr. Epel.
Thank you so much, Arianne. So we are gathered today. The impetus was and has been the Southern California fires. We are also in a very chaotic and dark period of political transition where protections to climate and safety networks are being stripped away, or at least attempts. And I would like to invoke Mr. Rogers' mother, who said, "In these difficult times, look for the helpers." So we have brought you the meta helpers, leaders in their fields, and they have important and complementary lessons to share with us. And you all are also the helpers. What is psychological safety training? It really means if you get this training, anyone can be a helper. We are next in line for experiencing our own disasters in our own communities. And so we need to both manage our own responses, especially if we want to be a helper, as well as have some basic skills for helping people navigate these really critical periods. We will be having more disasters, and clearly this is a topic that brings together people and builds on our resilience. So we are very lucky and happy to have Robin Cooper, who is a psychiatrist and a volunteer faculty in our department at UCSF. And she is a pillar of both inspiration and resilience, training our own residents as well as us in organizing around climate mental health. She's the co-founder of the Climate Psychiatry Alliance, and she will be giving us an invaluable overview on the trajectory of disasters, the mental health trajectory, what to expect, and how we can build resilience. And then we get to hear from Dr. Shannon Thyne, who is the vice chair of the Department of Pediatrics at UCLA, the director of pediatrics for the LA County Department of Public Services. She is a leader in her daytime job, leading the ACEs Aware initiative that brings trauma screening and connection to services into the medical healthcare system. So on top of that, she's become a pillar of strength for her own community, and you will hear her story. And I think the phenomenal thing about disasters is the community networks that can arise that are lifelines. And so she will generously share her own experience. And then lastly, we get to hear Dr. Epel Naturale, who is the Vice President for Disaster Services at Vibrant Emotional Health. And many of us here were lucky enough to have a 2-hour training with Epel and her colleagues focused on psychological safety in terms of the very basic foundation. So we're going to hear quite a short version of that, and she'll point you to longer versions of training and certification. And she has been a pioneer, and everyone knows Epel from the biggest disasters we've faced in our country. She is there in her body helping as well as training people. So welcome, Epel. Okay, so we will start with Robin, and we'll have lots of time at the end for Q&A. So remember to put your questions in the Q&A box. Thank you.
And thank you very much, Elissa, for the introduction and setting the stage of where we are in the world now. You've said that we will have more disasters, and you've also identified the tumultuous times that we're in. And though I'm pleased to be here today, I can also say it troubles me that we have to face this reality. This will be a quick overview of the acute disasters and the emotional responses that we see in acute disasters, often associated with climate change. Next slide, please. And I'm going to do this quickly, and we're going to review some of the things that are covered in this area. I want you to understand the mental health impacts and what is expected about emotional responses that are related to climate disasters, to understand the phases, to identify some resiliency factors and vulnerabilities, and to recognize the interconnection of disasters we're facing with climate change. Next slide. So all acute disasters are local. They're very specific to the region that people live in and exist in. And we've seen this around the countries: hurricanes, severe storms. Today, flooding in the Russian River area in California, and wildfires. That is our local California Western disaster. And next slide, please. We are seeing these grow and grow and grow, no doubt. Now, I want to make it very clear. The Los Angeles fire is a wildfire in a very dense, urban, large city. This is a wildfire, not an urban fire. Wildfire fighting is a different kettle of fish than city firefighting, and requires new ways of thinking about what we're facing. I caution us to put our anger at the situations that we're facing into finger pointing and blaming. The fire hydrants, the water supply, the firefighters who didn't respond, or even Gavin Newsom for supporting the smelt fish and creating troubles. What is important about the LA fire, although it is tragic for those who have experienced it, is it wakens up to this new landscape that we're in. that this is an important awakening as we face these growing types of disasters. Next slide. So there are very typical kinds of things that happen during acute disasters. And this represents some of the behavioral and emotional responses. Everyone has distress reactions when they're faced with acute disasters: anxiety, irritability, trouble concentrating, feeling overwhelmed and confused. And for some people, they have trouble figuring out how to manage these overwhelming feelings at the time of disasters and rely on some troubled coping behaviors. And we see increased alcohol and drug use and return to old smoking habits and such. A smaller group of people actually have the development of psychiatric disorders of depression, PTSD, anxiety, and complicated grief. And of course, those who have those conditions previously are more vulnerable to those being re-evoked. But look at that big circle, that purple one of resilience. Next slide. The good news is that most people, children and adults, bring strengths to them that pre-exist these acute disasters and can be the foundation of resilience. And this is just one little way of organizing our thinking about some of the factors that contribute to resiliency. Confidence, or a sense of positive view of oneself, and a sense of one's capacities and abilities that one can rely on. Connections, pre-existing caring relationships, and ability to tap into networks and community structures. Commitment to feeling a part of something bigger, something beyond oneself. A commitment to a cause or a goal can be some of those factors. And coping capacities, the ability to manage emotions, ways to manage and protect oneself. And I am unable to see the bottom one, the last C, and I assume that means those of you cannot also. But to say that there are resilient things that people bring to this acute situation. Next slide. Now, disasters occur according to a phase and a cycle. And I want to give you a warning. This is typical and varies dramatically depending on the time period and who one is and what type of disaster. But this gives us a sense that any moment in time is not static, and there will be changes. And it also tells us that there are things that we can do differently according to this phase of disasters. And that's very helpful for people and who are experiencing this and our own ways of intervening and helping. I want to notice the pre-disaster period. If there is one thing we have learned from LA, is that you have to be prepared before. And being prepared at the time of impact is a real problem. There are heroic phases where we all come together and a honeymoon and there's a cohesiveness, but inevitably there are periods of disillusionment and a sense of grief and hopelessness that can set in. And then this slide indicates that there are recoveries from those disasters. And that's very controversial, depending on the extent and who is impacted. Next slide. So the cumulative disasters and the cumulative impact of disasters being on the foundation of pre-existing social determinants of health represent some of the complexities in being able to recover. The fundamental issues that are within vulnerable groups of unemployment, poverty, racism, the added chronic stressors in those communities of low income, poor health, housing instability, and then additional acute stressors within communities. Those are the foundations upon which vulnerable communities experience acute disasters. Next slide, and make it more difficult to recover. This is a slide that just kind of shows you some of the range of troubling feelings, but I'm going to go to the next slide, please. Acute disasters always have normal distress responses, and people can look very unglued during a period of experiencing these normal distressed responses. This is not a time to identify people with pathology or do any diagnostics about how they are showing. Many of these are very normal responses. And I give you a minute to look at them. Trouble sleeping, being very anxious, sad, and depressed, a sense of numbness, changing emotions that feel very fluid, exhaustion, lack of appetite or eating, trouble concentrating, confusion, social isolation. Next slide. And children particularly have regressive kinds of things that are troubling to them. Pay attention to physical symptoms. Next slide, since children often are showing it that way. There are secondary impacts, and I'm going to go more quickly since I've gotten my alert of time. So next slide. No disaster acute it stands in isolation. There are additional things that happen. Next slide. And we've seen toxic ash and soil contamination. And next slide. Air pollution is a significant factor following wildfires and has been seen in LA and every wildfire. Next slide. But I want to just say, we are not in a state where, ooh, I had one disaster and it's over and I'm free and clear. Many people experience repeated and recurrent disasters, and that bodes poorly for mental health. Next slide. I'm going to leave you with this one thought, that wildfires contribute to climate change and are not only the disaster related to them. In California's wildfire carbon dioxide equivalent emissions from 2020 were nearly double the total greenhouse gas emission reductions achieved by the state since 2003. This means that wildfires not only contribute significantly to climate change, but can also undo the decades of emission reductions efforts that we've seen just in one season. And with that, I want to thank you for this rapid fire go through and look forward, next slide, to seeing you in our discussion period. Thank you very much.
Amazing blast. Thank you so much, Robin. That was so rich. And hopefully we can also share your slides on our website. We are so happy to welcome you, Shannon, and hear about your last month.
Great, thank you. As was mentioned, I'm Shannon Thyne, and my slides will come up in a minute. But I am a pediatrician. I work clinically at all of UCLA Medical Center, and I am not seeing the slides yet if others are, but I see patients for primary care and for sick visits, and I'm the director of pediatrics.
Let's get your slides up. So Annie, I think we're seeing your screen, not your slides. Sorry about that.
That's okay. I'll keep talking until they come up. But so I work across the public and private sectors, and my academic focus is on helping children and families respond to traumatic events, including adverse childhood experience, or ACEs. And this medical construct, I think, is helpful as we approach the fires, because what we see is that traumatic events in the absence of good buffers can contribute to toxic stress. And toxic stress contributes to poor health outcomes over time. And that's what we're obviously seeing here, and toxic in lots of different iterations of it. But in addition to my specific work with ACEs Aware, I've also worked with high-risk children. And over the last 5 years, unfortunately, done a lot around COVID and supporting children and families in COVID. And for the last couple of weeks also now working on supporting people around the fires. So I have a unique experience to bring here because I actually live in the middle of all of it. And I'm going to share a little bit about that and then try to put a framework using my medical background and also my personal and community focus to help share a few things that I've learned and that I think can be helpful to all of us as we move into this next phase around the fires. So they're really about communication, an acute response to crisis, and then most importantly, building a network of care to support longer-term recovery. Next slide. So I went to sleep on January 7th as the wind was getting out of control, and was awakened in the middle of the night by calls from work, friends, and family as the devastation of the fires began to take shape. This is a map of LA, and the numbers you see are what are called our service areas, but they're just basically the neighborhoods that LA is divided into. You can see it's a vast county, but this is sort of how I fit into all of it. The small fire near the number 2 was the Hearst fire, which is right next to that blue symbol, which is where I work at All of You Medical Center. The second fire near the number 5 is the Palisades fire, which is close to UCLA, where I also work. And then the fire on the right side of the screen, which looks alarmingly close to that house with the green roof, is where I live. And I was just far enough from the fire to be safe-ish, but close enough to have embers falling in our yard and trees that were down by the wind. So I really had it coming from all angles. And on the 8th and 9th of January, my house was filled with 2 new cats, 1 new dog, my brother, a friend and her 86-year-old mother, and a couple who lived in the fire zone. My kids were home from school, and my brother-in-law, who's a firefighter, was on the beach in the Palisades fighting an absolutely unwinnable battle. Next slide. So I learned a lot, and I tried to use all of the things that I have in my internal resources, my training, and in my community to try to figure out how to be a part of what happens next. And also as a human to try to focus on my internal resources so that this trauma for me would not be overwhelming. And so as the night and subsequent days unfolded, what I first realized was how fortunate I was to be a healthcare worker and in the know. I got real information that was accurate in real time. And that is so important. I knew where the Hearst fire was, and I knew that there was a line of firefighters blocking the fire's progress toward the hospital. So I knew my patients were safe. I knew from the front lines what was happening in the Palisades from my brother-in-law, and I knew from my family members who were evacuating exactly what was going on. I felt informed, and I felt a little bit less powerless than a lot of people. And so for me, the take home here is take the time when you can to share accurate and relevant information. So whatever is going on, if you have that capacity, share that with others because it is so, so important. So for me, what did that translate to? I sent emails to my department every 4 hours so that people knew what I knew and tried to make sure that over those 3 days that people I worked with and people in my personal life knew as much as they could about what was going on. And we all have different modalities and talk, text, and web. We had Snapchats, we had group chats. Some people still have pagers, all of those things, and making sure that we could communicate was really, really essential. Next slide. So thinking about what that communication meant was really about how to organize. And so I live in Pasadena. It's a mile south of Altadena. So I was right in it. All the schools were closed. the convention center opened for evacuees, and I was a doctor trying to take care of all of this. And what I realized is that knowing those things and figuring out how to build your community is the best way to move on to what you need to do next. So many people in my community stepped up to help each other. It was my work family, my school family, all of us communicating to try to make sure that people were getting what they needed. So just like during COVID, those who had capacity stepped up to support each other. And this is so, so important. And I credit my school community and my work community for helping people feel safe and informed and for being flexible and pivoting. Examples being our school set up a big room full of stuff for people who needed stuff. And when they realized that everybody had enough stuff, they took that stuff somewhere else and started focusing on helping people find places to eat and stay and sleep, places to get their laundry done. They didn't need new clothes. They just needed to help manage some other things. And being able to pivot was really, really, really important. So when you think of building a network of care, what I really want to do is share that I think that the way we help people is important, and we can all do it. We can engage across sectors to support on a larger scale. For example, as a network with different entities, we can bring our skill sets together into a coordinated system. And for me, watching this happen through the ACEs Aware initiative, where people use their clinical provider, the other support members of the team in the hospital setting, and then reach out through online access resources or community partnerships, and see that that helps buffer against stress. I've watched that happen in the setting of these fires and really see how important that is. A successful network needs to have a communication strategy, ways for people to get in touch with each other to get information to those who need it. In LA County, we use this portal called 1Degree, which is an open access portal. We also have 211, which many people have in their communities. And the healthcare systems have lots of different online portals that help people connect. I think these were so, so important to all of us during this time. I also recognize that I live in communities that were well supported to respond to the fire, because we were just far enough away that many of us could support people who were right in it. But I also think that there are people in many communities, just like Robin mentioned earlier, that have challenges that didn't go away just because there were fires. There's food insecurity, transportation challenges, and when you layer this on top of that, it becomes just harder. And what I think happened in all of the settings where I work, and I mostly work in a public health setting with patients who are already facing many challenges, is that people came together and used what skills they had to help each other. And whether they were simple things like, I can help move the debris out of the road so you can get your car out, to I can provide you food, to I can provide you medical care, or I can provide you masks. I really feel like working together in those areas to build a partnership that then leads to support and linkage to what people need is so, so important. I found my city, and I know this happened in Pasadena and Altadena, as well as in the Palisades, really came together to try to provide resources to people to give them information. Next slide. Really now thinking about the future, what is the long haul going to look like? Recovery is the next step. And so many people who, like me, who've been energized at the beginning, we're going to have our lows. And what we're going to need to do is figure out how to support each other and buffer through this. This acute phase is the beginning of a really long road. And again, for me, I think community and communicating with that community is the most important initial step. But then I also think, as we try to build resilience and help each other, recognizing that everyone can help is a key next step. Make a meal, give a ride, start a GoFundMe, foster someone's pet. All of those things, not only do they help other people, but they help you as an individual focus on recovery. And I do think we will need to continue to organize networks of care. And I think as we as we think about this disaster, the other challenges that we're all facing in the social environment that is our new reality, figuring out how to build a network that can allow us to support each other and build resilience is going to be so important. We saw UCLA students who needed to know whether to come to work. They were scared about their grades and their learning, but they also were scared about their safety. We needed to share information with them to make them understand how to best engage. We gave days off when they needed it. We allowed them to come to work if that made them feel better. The same thing happened in neighborhoods. My neighbors needed help cleaning their yards. Some needed places to stay. Some needed other supports like a long-term housing or a new car. And as we build these networks within our UCLA framework, in my case, or the UC framework, or in the communities we live in, it's really important to think about being flexible and pivoting. And for me, the key to all of this was, again, communication. And this is my last slide. Next slide. So I want to end with a reminder that comes back to the networks of care that we've created in Los Angeles around adverse childhood experience. Even though this event or these fires happen to us all as adults, so they're not technically ACEs or adverse childhood experiences, like COVID, this was a real trauma for all of us. And we need to acknowledge and take the steps that are necessary to do good self-care so that we don't have long-term health consequences. I think COVID really helped us all understand that health and well-being are more than getting shots and getting vaccine and getting medications. It's really about building resilience and having a social environment that supports you. The same is here. As we emerge from this latest trauma, I hope we can collectively build networks to support optimal recovery, whether it's our physical environment or our internal health and well-being. Most of you don't know me personally, but I am an absolute glass half full person, and ever the optimist. And the way I approach things like this is to say, what is it that I can do to help? Because that helps me stay strong and help others. And there's so many things we can't control. And I think, again, in the larger climate that we're all dealing with right now, there's so much what we can't control. And my takeaway point for myself, recognizing that I had many resources to support me, and in some ways just got really lucky that those fires weren't right on top of me. But I'm just so grateful that I found meaning and purpose in the response to these fires, and really feel fortunate to have chosen this career and life path, and to have both the personal community and professional communities around me that support all of our recovery. And it's really my hope that others across the UC system can find ways to find this same meaning as we help our friends and colleagues navigate the road ahead.
Oh,
Thank
so
you.
beautiful. Shannon, thank you so much. It's so moving to hear about you and your community, and how you've been able to respond. We loved hearing also when we met earlier about your weekly dinner where you invite people over who've lost their homes and don't have a kitchen.
Yes, so I've decided I don't have a lot to offer, but every Sunday somebody from the community gets to have not takeout at my house. So, yes.
Yeah. And I love how you reiterated Robin's point about what you've learned, the networks, that we can build now. It's about preparation. Resilience doesn't just come in recovery, but really what we're all doing together right now. And that brings me to April. Thank you so much, April.
Of course, and it's such a rich conversation, Dr. Epel, and I'm so pleased to have this opportunity to talk with folks. You've heard from Robin, and she went over a lot of really good specifics, which I love. And then Shannon, talking about what this feels like on the ground with somebody who's been in the middle of it. That's a really good way to learn as well. Obviously, we can't train you on psychological first aid in this short amount of time, but I will be giving you the links so that you can do that at your leisure and explain that a little bit more. For years, we actually didn't have a good best practice. We still don't have gold standard research about what is the best thing that works. in the immediate aftermath of a disaster. This is the time we call when we have an acute stress reaction. As you heard from Robin, it's different than being diagnosed with a mental illness. And the research is very, very consistent for decades already. No matter what the size, scope, or type of event that happens, it's pretty consistent that about 90% of the people get better on their own, get onto a recovery path in a fairly reasonable amount of time with good coping and good social supports. Most don't need formal mental health treatment. Of course, at any time anybody feels that that would be helpful to them, we encourage them to go. Let me explain too that in an event where it's a human-caused event with intent to harm, the numbers drop a little bit. We see about 80% of the people do well on their own with good social support and good coping, and that's because it's so difficult for us to understand how humans can do anything to one another so awfully and cause such harm. But what we know, again, is with some practicalities that you'll learn in psychological first aid, we can help people get on a recovery path, usually a little bit quicker, and understand more of what's happening to them. We know, too, that if people think they're doing poorly and that they're going to get PTSD just because they've been in this event, that they actually will fare more poorly. And so we want to make sure that people understand that their reactions are expected, that they're very common. And we talk about what some of those reactions are, from anxiety to fear to sleeplessness. And it helps people to understand it's not just me, this is expected, and that these symptoms usually do minimize and dissipate, again, in a reasonable amount of time. I think the PFA training is important too, because sometimes what we have learned previously as mental health or healthcare professionals doesn't work when we're talking with acute traumatic stress. So some of the things we do are intuitive, but some of them aren't. For example, if you're a mental health professional who tries to probe how someone is feeling, you'll probably get a lot of pushback from people in the immediate aftermath of an event. They may even get angry. Now, I hear all the time, I don't have time for this. I have to find a home. I have to take care of my kids. I have to make sure that I'm paying my bills and fill out all these forms. And so the PFA allows you to see what are some of the more practical things that might be helpful and how to engage with people in the midst of a traumatic event in these early days. So you might ask, how are they managing? Do they have everything that they need? And how can we help them, rather than trying to explore feelings or go back and find out how they coped before? We do stress what we call the core four basics, like getting good sleep, which will change your life. And it is the number one complaint that I've heard from every population that I've ever worked with anywhere in the globe, whether it's child soldiers or responders or people from a terrorist attack, people who are moved from one house to another, people who've been in a fire, people who've been in a mass violence incident. It is the number one issue. And so we really do stress with people that sleep is incredibly important, rest and sleep in these times. Obviously, eating healthy and mindfulness or cognitive rest, kind of giving themselves a break from talking about this event all the time, from listening to the news, and especially, as you heard from Dr. Epel, with the addition of the political strife that we're going through, people can become very, very overwhelmed, and it keeps stress hormones high up in the body. And when we talk about the core four and basic exercise, we really mean the do no harm types of things that also help people calm themselves. So breathing exercises, number one, top of the list. Can't have a panic attack and breathe deeply at the same time, right? So we always want to teach breathing, stretching, which moves stress hormones through and out of the body. And walking, something that's really easy to do, especially if you're out in the field and you don't have an office, which mostly we don't as disaster responders. We're out in the community. And so walking with people, again, helps move stress hormones through the body, gets their blood moving, just helps, especially if they're able to be in a safe place and in nature, that helps to calm them. We teach grounding exercises, positive ways of coping as opposed to negative coping. Again, some of these make more sense, but when you take the overall psychological first aid course, it really does help you to see what are the most practical ways to work with people. We actually do help people to understand that if they connect with others who understand and accept how they feel, that they'll usually do better. Many of us as health professionals or mental health professionals, we've been trained, make a diagnosis, write a treatment plan, do formal treatment. And so we're asking people to kind of put that in a box and on a shelf for a little while. And we do more caring for, being with, and having a compassionate presence with people. And again, as we look at the ways that we try to engage with people and help them to understand what might help them most, we make a connection and help them to feel as though they are not alone. Very, very important piece of psychological first aid. Also, what we have learned over the years is that there really is no recovery time frame, that people get on a recovery path and move in their own time. For many, that can take weeks or months. For others, it can take years. We just want to make sure that they are on a path and moving ahead in a way that's helpful to them and not kind of off to the side, on the rocks, alone and not moving forward. And so we don't give people specific time frames as to when, they're going to start to feel better. We also do make sure that they understand and know that there may be different time frames that reactivate some distressing symptoms. So whether it's an anniversary, a birthday, holidays, and this can happen for years. We help people to understand to expect that. Again, it doesn't mean they're developing a mental illness. And also what we know from the research is that there is a buildup of symptoms in the anticipation of those timeframes, and then there's usually a very significant drop in symptoms right after that time frame. In the first year, we hear survivors and family members, they call that the year of firsts. It's the first holiday, the first birthday, the first summer, the first vacation. And they say they feel like they take a big, deep breath after that first year. We got through that. Now it's going to be better. Now things will improve. So it's interesting that we hear from survivors that these are things that they find really helpful to know ahead of time. So we want to make sure that we're sharing good information. You heard Shannon talk about that as well. Communications are extraordinarily important. We want to make sure that people are getting the information they need that's timely and accurate. And again, as a mental health professional, I have to say, we used to do what we call slice the bologna. Tell me what you saw, tell me what you heard, how did you feel? And thought we needed to do this in order for people to heal from a trauma. And maybe most people will do it that way. Ask them, how's it going? How are you managing? And they'll start talking to you right away. But we do know now that prompting people to tell us specifics, what did they see? What did they hear? What did they smell? Can reactivate and re-traumatize them. And so we don't urge doing that. As a matter of fact, we know we can help people reduce symptoms without even knowing what the trauma is. And so we don't overly activate them to remember things. We talk about symptoms and what are the best ways to cope with and reduce those symptoms. So anyway, there's a lot that we can do. You'll see the psychological first aid training, and I'm going to pull up a couple of slides so that I can give you some resources, because I think you heard both Robin and Shannon talk about the fact that resources are really important. We want to make sure that people know that they are not alone. And there are others out there who can really help and give them some good information and repeat things, because as you know, when we're under stress, we don't remember so easily. So let me share my screen and get this onto a show so that I can give you some good resources. The 988 Suicide and Crisis Line has over 200 crisis centers and about 10,000 highly trained staff answering the phones. Most of the calls are not suicide calls. Many of them are crisis calls. And the staff are trained to stay on the phone and help people to calm themselves, give them information, provide support, and teach them some good coping. Part of the 988 Suicide and Crisis Line is also the Disaster Distress Helpline. And what that means is it's the same people answering the phone We just learned after Hurricane Katrina that some people just refuse to call a suicide or crisis line, but they will call the disaster distress helpline after a disaster. So again, it's the same trained crisis counselors. They have vast numbers of resources in the local communities across the country and can help people to access services that are right there with them in their communities. And that changes like constantly, as you probably have seen, those of you who are responding to the fires, you know that every day there are different resources. These resources and information are in English and Spanish, and there's different ways to access, but the easiest ways to do that are to call 988, and you can text 988 or the disaster distress helpline as well. For many of you on the line, we wanted to make sure that you knew that there is a specific physician support line. We understand that psychiatrists, medical staff tend to have a sense that they want to connect with others who understand and accept how they feel in their professions. This is especially important when there are a lot of people who are injured. So this is a specific support line separate from 988 that physicians can call. It's free, confidential, and anonymous. And again, people can call for any kind of a crisis, any kind of an issue. I think we saw Robin shared the model for adaptive response to complex cyclic disasters. It really gives us a good sense of how to evaluate the community. What were the foundational issues that they may have been dealing with before this happened? What's their experience with government? What's their experience with accepting help? What's their understanding of health and mental health? And what's their understanding of mental illness? So this is a QR code. You can just use your phone to click on it or go just to markd.info, and you'll be able to pull up the entire model so that you can get the instruction and use it at any time that you feel it might be helpful to you. We use it in our evaluations, in our needs assessment, at several times in the different responses. And as you heard both of the previous speakers, this is going to be a long-term response. So it will be helpful to have different intervals where you actually evaluate what's going on. And the key slide here I'm going to leave up for a while is our psychological first aid slide. The link here, and you can just Google psychological first aid online training, but the link is here also. This is the best practice, the only evidence-informed intervention that we have for acute traumatic stress. It was developed by our colleagues at the National Center for Post-Traumatic Stress Disorder and the National Child Traumatic Stress Network. You can take this training, anyone can take the training. You do have to register, but you don't have to pay for it. It's 6 hours. You can stop and start it so that you don't have to sit there through the whole 6 hours. You won't lose your progress, and you will get a certificate. And for those of you who want 6 free CEUs. Again, it basically teaches anyone, you don't have to be a mental health or healthcare professional to take psychological first aid and to gain an understanding. Really, what we want you to do is come out with a sense of confidence and competence that you can engage in ways with people who have suffered through a traumatic stress incident like a disaster and feel like you've offered help and did no harm, that you've been able to help people feel cared for and cared about, and provide a compassionate, attentive presence with them. And so again, we teach basic ways of helping people to manage in the immediate after of a disaster and terrorism. It's for anyone who wants to learn how to do this. What we hear from those who are experienced mental health professionals who've taken lots of training is that they get this. They can move through the training actually pretty quickly. So I wanted to make sure that you have this. Again, if you can't copy off the link here, just Google psychological first aid online training. And my contact information is on the bottom here. Vibrant is the administrator of the 988 Suicide and Crisis Line and the Disaster Distress Helpline. And we have a cadre of about 1,000 responders, mental health responders, that we deploy across the country in the immediate aftermath when the community has asked us to do so and might need some help. I think, Dr. Epel, there was one question about a training of trainers for psychological first aid. Dr. Patricia Watson, one of the authors, does go around and give trainings. And I will stop my share and I can put in the chat her contact information.
Great. April, thank you so much. These resources are invaluable. Someone asked, is this pointed out this is not the training webinar. That's right. So there's a 2-hour training from April and her colleagues on the website that we posted earlier, which is climateresilience.online. There is, April gave you the other links for trainings, including being certified, and that's a 6-hour training. So there are so many important points here. I'd like to, yes, we have Robin and Shannon, and we'll have some, get to address some of these fabulous questions. In the meantime, we would love to see who's with us. We don't get to see your faces, but if you want to share your names and your role or relevance to this topic, we would love to see. That's part of the how we try to feel community, even though it's a webinar. So the point about don't slice the bologna, don't get really specific with the trauma. It's just so important, given that the skill set, is different. Any therapist who's not trained in disaster response might go there. So it's just such an important, unique training. The other point that both you and Shannon made about community networks and community resources, connecting people to these is the most important. And one of the things that UCLA is doing is providing a network among the community players, rather than just trying to help individuals or trying to, affect policy. It's the meso layer of all of the organizations being connected and working together that is so important in disaster response. We are teaching our undergraduates at the all UC campuses a course on climate resilience. We launched last year. It was wildly successful. Any student at any UC can take it this year. It's on the same website. And I mention it because after the Los Angeles fires started, we realized that we were all lacking in these skills, and that rather than just teaching climate resilience to the students, more long-term ways of coping with our climate distress and fueling that into advocacy, we are now teaching them psychological first aid. So thank you, April. That was directly from you, as well as this model of really working with the community and realizing that's one of the ways to help, donating money if you're from afar. One of our questions was, I'm already trained in disaster response. How can I help the Los Angeles community? And I guess a naive question that you might address, both April and Shannon, is what you see this many days out. How many days or weeks out does psychological first aid responders, do they have a critical role?
That's a really good question. As I said earlier, Dr. Epel, I think it does depend on your comfort level and how you do this, because early on we know that we have to follow Maslow's hierarchy. People need safety first, the basics of food, shelter, and water. People are going to be talking about taking care of their children, and making sure that their family is safe, that they have a place to stay. Again, early on, it's great to have folks who do some concrete things. In the early days after 9/11, I can't tell you how much water I handed out. That was something the responders needed and the families needed when we were down at ground zero. And they started talking right away. So I didn't feel like I had to do an intervention. It was being there. It was being a compassionate presence. So that can be very, very helpful. But as people start to get a sense of what their losses are and what they're struggling with, then it's helpful to have a presence. So we do talk about people going in a week to 2 weeks later. You'll get folks, some who are very pragmatic and very practical, and they want to know, how do I stop, having a panic attack? How do I get my breathing regulated? What do I do about not sleeping? And we can start to engage in ways that can help them reduce symptoms fairly early on. And we could do some of this work even years later, because sometimes it takes some people many years to even recognize that they're having symptoms from this. So it goes really from one end to the other, as long as you have a comfort level with making sure you're doing no harm and that you're being there in a way that the person needs you, rather than us imposing what we think we need to do at the time.
Beautiful.
I'll just add briefly to that. One of the things that we've learned from screening for trauma is just because you don't ask doesn't mean something isn't happening. And so what we have all tried to do as a collective healthcare community here is continue to query our patients about how they're doing in response to this event. Even if it seems longer out and people say, oh, you don't want to bring up the fires again, that's actually not necessarily the best approach, because it's not necessarily re-traumatizing. It actually is offering an opportunity to continue to share if you want to, or if you don't want to, but it also normalizes discussion about it. And I think that's a really important part of ongoing self-care, because as April said, you have no idea how long someone is going to continue to suffer. And if you don't ask, it doesn't mean it's not happening.
Such important points, Robin.
Elissa, I wanted also to underscore a few thoughts that have come up both in other people's conversations, but underscore them, highlight them. One of the things that I think Shannon has addressed, and also April, but I want to say it in a different way. One of the ways, and the question has come up, how can we help people? It's come up in a lot of ways in the Q&A, is everyone comes in with some strengths, but they don't know what they are good at when they're flooded with so much trouble and so much worry. And so if you can help people identify, I'm good at, I can give back massages, I know how to braid hair, or whatever it is. What it helps do is pull out, I am a victim, I am helpless, and builds on what Shannon has said as I can do. And that's not solving things, but it is one of the ways that you can help. The other question for April that has come up is, after the acute period, we're now in the post-acute, what are the ways for helping? And we haven't addressed that today. I don't think we will in a half a minute, but it's a really important one. And there are a number of incredible questions that have come up that I wish we had time to talk about.
Yeah, would be great. I just want to say thank you again for that, Robin, because we know that people's strengths really are what help them to get through, and that most people really do recognize that, gee, I can actually manage this. You know, I do have this ability. I do have these friends. I do have this support. I know how to do this or that. And they start to recognize some of their own strengths. Dr. Bonanno's research says that's pretty, typical. But I do want to emphasize you can apply PFA really at any time. It really depends on where the person is at. If they continue to have symptoms, though, you're right. Dr. Jessica Hamblin has developed CBT for post-disaster distress, a short 10-session model of helping people to decrease symptoms. It's been published in the Mental Health Administration. She's worked with people from 9/11 to Florida hurricanes to Katrina to Sandy to the Boston Marathon. Very good result. It's a short-term, even for people who've never had formal mental health treatment or aren't psychologically minded. We know that EMDR helps people who've not had a long-term chronic trauma, but are dealing with something immediate. So there are several different types of treatment, but CBT still is the highest in research, other than exposure. But when you even talk to the woman who developed exposure, her name went out of my mind right now, there's still a 50% rate of folks who can't tolerate the exposure. So even she, Edna Foa, suggested that CBT still remain the first offering.
Mm-hmm. Amazing. The helpers are all here. Amazing chat going. Thank you so much for being here. I'd like to close with Dr. Teherani.
Thank you, everybody. Boy, if you just see the comments, this is clearly proven to be a phenomenal webinar. Thank you very much for all of your input and insight. I want to remind those who are left, which is still quite a number of people on the call, that next week we're going to have another webinar on community impacts and recovery. The moderator will be Dr. Sherry Weiser from UCSF, and it's going to include a slate of speakers who will provide guidance on financial distress, housing insecurity, food insecurity, insurance impacts, and disproportionate impacts. Thank you all very much, and we look forward to seeing you next week.
Thank you.
Thank you.